Hey guys, welcome back and welcome to the pathology section of this chapter, the bread and butter of MSK. Be forewarned, there are a lot of diseases listed, but remember, this is a section to come back to a few times, review the major diseases covered, and look for key distinguishing features of each disease to keep them all straight. Let's get started. The first disease we'll discuss is called achondroplasia. Remember the concept of endochondral ossification? Well, this is what happens when it doesn't work. Normally, patients will put down a cartilage framework to help form the structure of their long bones before forming bone over the scaffold. In this case, a constitutive activation of FGFR3 inhibits the chondrocytes, which form cartilage, from proliferating. This means patients can't grow out their limbs and end up short. That being said, remember not all bones grow by endochondral ossification. Do you remember which bones, long bones or flat bones, don't? Right. Flat bones grow via membranous ossification. Because there is no problem with membranous ossification in these patients, they will have a normal-sized head and trunk, though because their limbs are short, they will appear disproportionately large. So what will they ask you about this curious disease? There are a couple of high-yield concepts about achondroplasia that you should know. First, this is one of only a few diseases that increases with advanced paternal age. Most patients develop the disease spontaneously, but if it's inherited, it's in an autosomal dominant pattern. Another important fact to know is that these patients will have a normal lifespan and fertility. Flash quiz. What bone cells are responsible for resorption and bone remodeling? Answer: osteoclasts. Osteoporosis is an extremely common disease, and as is the spirit of Step 1 exams, common diseases are always well represented in their question bank. Osteoporosis is defined as a reduction of primarily trabecular bone mass despite normal bone mineralization and lab values. You see how this spine x-ray just seems a little too translucent? Now, not all osteoporosis is the same. There are technically two different types of osteoporosis. Type 1 is postmenopausal. Do you recall the effect of estrogen on bone? Estrogen is anabolic. In menopause, decreased estrogen levels can increase bone resorption. Type 2, on the other hand, is a slow but steady loss of bone mass with age, leading to osteoporosis. How do we assess osteoporosis? Well, we use a DEXA scan and T-scores. The bone mass at multiple different sites is measured using this scan and is compared against the bone mass for young individuals. If the bone mass is 2.5 standard deviations below the mean, they are considered to be osteoporotic. If the bone mass is 1 to 2.5 standard deviations below the mean, they are considered to be osteopenic. You can review standard deviations in the biostats chapter. Now, there are many clinical signs of osteoporosis. The first one, and one of the more common ones, is vertebral compression fractures, which clinically present as acute or subacute back pain, sometimes after mild traumas, but often after no real trauma at all. Patients with osteoporosis can simply step off a curb and get a vertebral crush fracture. The classic clinical sign for this, you'll see on the exam, is point tenderness over the spine, usually along the thoracic spine. Now, often these won't fracture quickly, but will fracture gradually, leading to multiple subclinical vertebral fractures. Now, these won't present as back pain, but rather loss of height and kyphosis. Just imagine the 5'2" woman who then gets her height measured at 4'10" at her doctor's office. Now, what do you call this type of kyphosis? Well, this is called a dowager's hump. Now, think about your respiratory chapter. What do you think this deformity does to total lung capacity? Very good, it decreases it. A second clinical presentation is with fracture of long bones like the femoral neck or the distal radius, which is called a Colles fracture. This happens after a fall onto an outstretched hand. Look out for medications that can cause osteoporosis after long-term use, such as steroids, anticonvulsants, anticoagulants, and thyroid replacement therapy. These will all be long-standing medications. Another classic question they like to ask about patients with osteoporosis is the medications that you can give them, not to treat osteoporosis, but rather to treat other conditions in patients with pre-existing osteoporosis. Remember, old people fall down a lot. What happens if they have osteoporosis and fall down? Well, they break bones and in some cases even die. If you give them something that can cause them to fall down more, they'll break more bones and have an even greater chance of death. So, you'll have an old patient with insomnia, and they'll give you 4 options. Zolpidem, a benzodiazepine, and diphenhydramine are the first 3. All of them would work, but they all increase fall risk. The 4th option would be to screen for depression. Not a first choice for all doctors, but definitely safe to do, and worth doing because depression in the elderly can present atypically. Remember to screen for depression and to avoid drugs that can increase drowsiness and affect balance, causing increased falls. So if a patient actually does have osteoporosis, what would you think they could do for it? Prevention is important to emphasize in young adults. Recommend exercising and increasing calcium and vitamin D intake to improve peak bone mass, which generally occurs when patients are in their mid-30s. But even though you can't reverse time, you still have some other options. One is to use bisphosphonates, which are very commonly prescribed. These drugs stop the action of osteoclasts. Other options include certain selective estrogen receptor modulators, or SERMs. You can also use calcitonin or pulsatile PTH. We'll discuss the more common ones in the pharmacology section. Don't use drugs whose side effect profile includes loss of bone density. Can you name a common class of anti-inflammatory drugs that this includes? Well, glucocorticoids are the classic ones. You'll read in your pharmacology chapter that it also includes heparin. Osteopetrosis is an interesting disease and relates to an aspect of bone growth that we haven't touched on in much detail. When you form bone, there's sort of a battle that is going on between osteoblasts and osteoclasts. Osteoblasts are forming bone quickly to ensure growth progresses steadily, but this often leads to bone being formed in a way that is a bit haphazard and not refined into a good structure, like that which is needed in healthy, mature bone. Luckily, most people have osteoclasts to reshape this haphazardly placed bone by resorption. This ensures it is mature and well organized. Patients with osteopetrosis don't have normal osteoclast activity. This leads to them having thick, dense bones that are made of an immature substance. This X-ray shows dramatically dense bones. So even though you'd think bone would be extra thick and hence extra strong, these bones lack the refining and remodeling process and actually are prone to fracture. In normal, healthy bone, the center of bone is hollow enough for bone marrow to fill it. What happens in osteopetrosis? Well, the marrow cavities are actually filled in. So what happens if you don't have much bone marrow because it's been displaced? Anemia, thrombocytopenia, and neutropenia, which can predispose to infection. This causes an increase in extramedullary hematopoiesis, which, as you recall from the hematology chapter, refers to blood that is created outside of the normal bone marrow. It does not, however, cause any changes in serum calcium or phosphate, or in alkaline phosphatase or PTH levels, much like osteoporosis. The gene defect to recall for osteopetrosis is a genetic deficiency in carbonic anhydrase II. The X-ray findings are classically noted as bone-in-bone or Erlenmeyer flask bones that flare outwards. The clinical pearl that you need to remember, the sort of physical exam sign that would make you think of osteopetrosis, occurs because bone enlargement narrows the foramina, causing cranial nerve impingement and cranial nerve palsies. So which would you rather, osteoporosis or osteopetrosis? For me, although these bones are pathophysiologically total opposites, they tend to end up with the same, fragile bone that fractures easily. But osteopetrosis comes with a bunch of other complications like cytopenia and extramedullary hematopoiesis, so I'd have to go with osteoporosis. Flash quiz. How do bisphosphonates work? They stop the action of osteoclasts. Osteomalacia is a disease wherein bone is not mineralized appropriately. Basically, this results in bones being softer than they should be, with characteristic bowing of the long bones. Osteomalacia is due to a deficiency in vitamin D. Vitamin D, as you should remember from our endocrine lectures, is an important regulator of calcium levels in the body. Because calcium is low, patients will have a reflex increase in PTH, which will also decrease phosphate levels. Remember that PTH is the phosphate trashing hormone. If you are suspecting osteomalacia, these lab values would definitely confirm your diagnosis. Now, why is alkaline phosphatase increased? Well, because osteoblasts require an alkaline environment and are hyperactive in this disease trying to build bone. The term rickets is not much different from osteomalacia, except that it refers to more specifically vitamin D deficiency in kids. Would you expect to see an increase in PTH in kids with rickets? Yes, you would. Flash quiz. What bone cell is affected in osteopetrosis? Osteoclasts. Paget's disease is quite interesting, particularly because the cause remains unknown. Osteoblasts and osteoclasts in the body both function, but both work abnormally here. This causes the bone to appear much different than it would in an otherwise healthy individual. For example, here we see abnormal architecture, widened bone, disordered trabeculae, and a gross deformity. This X-ray shows sclerotic areas and coarse trabeculation in the pelvis. This appearance is not only at the macroscopic level, but also at the microscopic level when looking at the architecture of the bone histologically. This is also described as thickened trabeculae with the mosaic pattern. The thought is that a viral illness may play a part in its etiology, but that's still not confirmed. The classic lab value that's abnormal is increased ALP, a fact that you may see on your boards. With diseases like Paget's, there are two things you should try to pay attention to. 1. You should know the key catchphrases that will make the diagnosis, and 2. How the disease will kill you. So first, what are the catchphrases? Well, one is mosaic bone pattern, on macroscopic appearance, and even on imaging is a giveaway. Long bone chalk stick fractures are also common. Imagine the way chalk breaks, with a straight line across it axially. Healthy bone doesn't do that because it's designed to have a lot more resilience in that direction. But patients with Paget's, it's much easier to break the bone. How will Paget's kill you? Well, there's at least two ways it can kill you. The first is that AV shunts can form through the bone, causing high-output heart failure, which, as you'll recall from the cardiovascular lecture, refers to heart failure in which the heart is able to pump a normal amount of blood, but that blood volume is not sufficient to meet the body's needs. It can also lead to osteogenic sarcoma, again as a result of disordered bone growth. The classical clinical vignette will likely have an older male with increasing hat size and also hearing loss because of narrowing of the auditory foramen. While the latter could be similar to osteopetrosis, the labs, age group of the patient involved, and additional clinical findings all should help you differentiate the two. What should you order? Well, the first thing is an ALK-Phos level to confirm your suspicion for Paget's disease. This CT shows widened bone medullary space with areas of sclerosis and irregular cortex. Flash quiz. What is the effect of PTH on serum calcium? PTH increases serum calcium levels. Osteonecrosis, or avascular necrosis, occurs when the blood supply to the bone is interrupted. It often presents clinically as pain that occurs with activity. The pain is throbbing in nature. To help you recall all the causes of AVN, we have the mnemonic aseptic. The first A is alcoholism. Do you recall which type of hem-onc patient typically gets avascular necrosis? Correct, sickle cell patients. This usually happens in the femoral head due to infarction. Other things that can cause avascular necrosis are steroids, either endogenous or exogenous, pancreatitis, trauma, or idiopathic, such as Legg-Calvé-Perthes disease, or even Caisson's disease, also known as the bends. If the blood supply to the part of bone involved in a joint is affected, it can often lead to a destruction of the articular surface, causing significant joint pain. Now, what test would diagnose AVN? In X-ray, you'll see irregular, non-uniform patterns of lucency and opacity in the affected region, with possible joint changes if the articular surface is affected as well. What is the most common site of osteonecrosis? The femoral head. And why is this? Because the blood supply to the femoral head is already tenuous. Flash quiz. What disease would you expect if your patient tells you he has an increasing hat size and elevated alk phos? Correct. Paget disease.